we've done in past, and you guys can tell me if you want to do this or not, is that normally what we would do, you've only got 2 exams to do. So what we would do is do one starting at 9, finish that, have about half an hour break, do the other one, and then you're free. I see nods.
Yes.
Does that sound reasonable? Yes. Okay. The other thing I was going to mention to you is I communicated with the Chief of Security here at North Campus. Good morning.
Sorry.
That's okay. I communicated with the Chief of Security at North Campus about the Alice thing, and he said he would be delighted to come and talk to us about Alice and about active shooters on campus. So we'll organize that for some time. He said after spring break, so we'll organize that probably next week. I think you would probably want to get out of here next week. So we'll maybe do it the week after, okay? So for those of us who have just come in, I did mention that what we've done in the past is that since we've only got 2 midterms to do next week, we'll do the first one, which will be the oncology one, at 9. When that's finished, you'll have half an hour break, and then the next one, and then you guys can go. So what we're going to do today is we're going to go over what you might expect for midterm in oncology. So it will be head and neck, which is chapter 29. Urinary tract, which is 33, and breast, which is 34. So we'll go over some scenarios on those this morning. And you can ask questions, or you can ask general questions on either of these 3. What we were supposed to do on the syllabus was lymphatic tumors, but 1 week isn't going to do lymphatic tumors justice, so we'll do that starting the 29th. So all we'll be doing, we'll have 3 areas to do after spring break, or after, no, but after midterms, we'll have 3 more. Okay, so let's go ahead. So we'll start with head and neck. So what can you tell me about salivary tumors? What are where do the salivary tumors arise? So obviously in the salivary glands. Can you tell me the names of the salivary glands? Or salivary glands, call it what you will. What are the names of the salivary glands?
Parotid.
Parotid.
Submandibular.
Submandibular. And? There are others which are called usually accessory salivary glands or other salivary glands or small salivary glands. So there's really only 2 that we would be concerned with. Which is the most common? Parotid.
They rise
So-
in the parotid.
Pardon?
So they rise in the parotid.
Yeah,
Most
they
common
arise in the
in the
parotid
parotid.
gland, yeah. That is the most common site for a salivary gland tumor to occur, is in the parotid gland. Can anybody tell me how you can find the salivary gland using surface anatomy? I know we did surface anatomy last semester, but there is a way to find the salivary gland using surface anatomy. Does anybody know that? I'm not sure whether I mentioned it last semester or not.
Was it 5 centimeters over, 5 down?
What?
Was it 5 centimeters out and 5 down or something like that? It's kind of opposite of what you did for.
Oh boy.
For the pituitary.
The pituitary, yes. So it's actually 2.5 centimeters.
Oh, okay.
So the way I remember it is an inch out and an inch down. So 2.5 centimeters from the EAM anteriorly and 2.5 centimeters inferiorly. And that will get you approximately to the salivary gland, or to the parotid.
And what was for the pituitary gland, was it
It's 2.5 centimeters anterior, 2.5 centimeters superior. So one is for the pituitary, one is for the parotid. That's just a little piece of nonsense, but anyway, that's something that you can wow your therapist with. Would have been told that by me. So what's so special, we'll go on to the other parts of the head and neck. What's so special about the glottis? What does the glottis not have that almost every other part of the body has?
No.
What kind of nodes?
Lymph nodes?
Lymph nodes, yeah, you have to be more specific. Just don't say nodes, because that doesn't mean anything, right? So lymph nodes, yeah. The glottis has no lymphatic drainage. And you'll find out later on this semester the other areas that don't have any lymphatic drainage, but the glottis does not. So if you're looking at stage 1 larynx cancer, or stage 1 glottic cancer, it can be named either or. And they ask you, do you include lymphatic drainage in the site? Your answer would be no, because there ain't no. You don't have any drainage, so you can't include it. So what is in the glottis? What's particular structure is included in the glottis or in the larynx?
Vocal cords?
Pardon?
The vocal cords?
Which ones?
True.
Because there are false vocal cords. True vocal cords, yeah. So on that subject, somebody tell me, what does the epiglottis do? What does the epiglottis do? Sorry, say again?
Does it keep food from going down the respiratory tract? When you swallow it,
Yeah, and
it covers the.
yeah. So it stops food going down the respiratory tract. Yeah. So how does that help? I mean, what might you be doing to have the epiglottis do that?
Swallow?
swallowing, and if you're talking or laughing and trying to eat at the same time, has anybody had this problem?
Oh, yeah.
Yeah? Food goes down the wrong way. That means that the epiglottis sort of gets confused because it's supposed to stop food going down the respiratory tract. And if you're talking or laughing and you're eating at the same time, the poor epiglottis doesn't have a chance to do what it's supposed to do. And it fails and stuff comes down
What
the
happens
hole.
if you get food down there? How do you get that back out? The coughing is what would get that back out?
That's the way it usually does. And that's what happens if you have to do a Heimlich. Everybody knows how to do a Heimlich, right? Has anybody ever had to do it?
Well, my child once.
Okay.
Had it done.
Has it done? You're one of these people that walk and talk and eat at the same time, right?
In third grade, I choked on a ham and cheese sandwich.
Ouch. Yeah.
My teacher did.
Yeah, the teacher did it, yeah. Yeah, I've done it in a restaurant. But it was very, very embarrassing for the person I did it on. So what is, this is not actually in the text, but what is the international sign for your choking? Not that I've ever seen it actually done this way, but that's what it is, yeah. And you have to stop, somebody who is choking will try and get out of it. Try and get out of area, go to the bathroom, something like that. You have to stop them or follow them, whatever you want to do. So, anyway. So that's basically what the epiglottis does.
Choke on my own spit sometimes.
Pardon?
It's when I choke on my own spit.
Yeah,
I do it
okay.
often.
Do you want me to have more of that than you know what to do with, right?
Yeah.
Okay. So if we were treating the larynx and only, for example, a stage or a low, what they call a low stage larynx or a stage 1 larynx, what kind of field size were we talking about? Anybody? Anybody?
Is it 6 by 6?
6 by 6 or a 5 by 5, yeah. 5 by 5 or a 6 by 6. And we would do laterals, just plain laterals. And where would the posterior border of that field sit? So you have the larynx field and you're going in this way. Where would you stop posteriorly with the field?
Guess before the spine, at the spine. I don't know what the official
Okay,
term for it would be though.
okay. Anybody think of any other one? Any other area? You're right. It's called the anterior aspect of the spinal vertebra. Or the vertebral body, actually, is what it's called. And why is that? Why do we stop before the spine? Are we, go ahead.
I'm just gonna say, so we don't do neural damage, spinal damage?
Okay. So are we making sure that we don't damage the spine? Or are we making sure we don't damage something else?
Cord?
Spinal cord, yeah. Spinal damage is not really, we're not really worried about. The bones can take a fair amount of dose. It's the cord. For the larynx patients, you're only doing a 5x5 or a 6x6 field. You're going to 7,500 perhaps. What's your spinal cord tolerance? 45, maximum 45. So there's your answer. You have to stop shy of the cord. So to make it easy, you stop at the anterior aspect of the vertebral column or the vertebral body. And where's the vertebral body? Which part of the spine is the vertebral body? Okay, let's get Fred in here. Sorry, they moved him. Stabbing in teeth. Gonna have to yell at the guys. Okay, let's, can you move your foot in a wee bit there, dear? Thank you. Let's bring Fred over here. Okay, so here's the vertebra. We'll go with this one because it's easier, right? Where is the vertebral body? Which part of the spine is the vertebral body? Pardon? This part?
The round part.
This part?
Yes.
Okay. So if we're doing the larynx, it's up here. So we would stop right here. So we go lateral here, and we would stop at the anterior aspect. Just put them back here so that everybody can see what we're doing. Okay, so the anterior spine, yeah. Okay, so the head and neck, what type of histology is usually found in the head and neck? Pardon? Squamous. Finish it. Squamous cell carcinoma is the official name. As my father would say, it's Sunday name, you know. It's official name. Yeah, it's squamous cell carcinoma. So having said that, what is the normal histologic type of larynx cancer? Pardon? Squamous cell. SCC, squamous cell. Okay. So if you had somebody suffering or coming in to a physician's office, or you're asking your patient what was the first thing that he was complaining of, or the most common thing that he complained about for larynx cancer. Sorry, I missed that.
A sore throat?
Sore throat?
Or
Hoarseness.
Hoarseness is hoarseness is, sore throat comes a close second, but usually it's hoarseness. That's what usually brings them in. The problem with that is, can anybody tell me what the problem with hoarseness is? As far as head and neck cancers, all head and neck cancers. What's the most common complaint or the most common predisposing factor, I guess you would call it, is smoking. Smoking and drinking. So, I'm not even gonna ask if anybody smokes here, but if you know anybody who smokes, what does their voice sound like?
Horse.
It's hoarse. So this is a problem. Most people think that, okay, they're smoking, their voice is hoarse. It's a normal smoker's voice. Same with a cough. It's a normal smoker's cough. And sometimes it takes them a while to get in to see somebody that can look at it. But yeah, it's hoarseness usually. So let's go back to saliva for the moment. What does saliva do?
Breaks down food, keeps your mouth.
Breaks down food. Okay.
Chemically.
Pardon?
Chemically.
Chemically. Okay, it chemically breaks down food. What else does it do?
That's my input.
What?
That's my input. Chemically.
Okay.
Keeps your mouth warm.
Okay. What else does it do?
Lubricates the food to go down for
Lubricates the food. Yeah, same thing. Yeah. What else?
Makes you swallow every person.
It keeps.
Or choke.
Yeah. Mouth hygiene is what it's called. So it helps to get rid of some of the yuckiness in the mouth, the food. Pardon?
So if you ask that, that's what you're looking for, it's, that the saliva.
Yeah, well, there's several. So it aids digestion, right? If you have no saliva in your mouth, are you going to be comfortable eating? Why? Because it's dry and so you have to drink a lot. If you have a lot of saliva, which some of us have more than others, the food goes down a little bit more. So it helps get the food, what they call the food bolus, down. It aids in digestion, obviously. And it aids in what they call oral hygiene. The more saliva you get, officially the cleaner your mouth is.
Wow.
You must have a really clean mouth.
I guess so.
That of course does not obligate you not to clean your teeth, but yeah, okay. So if we had a tumor which was involving the cord, the vocal cords, what kind of stage would it be? So let's say it involves the vocal cords, but does not, what they call it, impair mobility. What stage would that be? So remember you have a T1, T2, T3, T4. And you also have T1A, B, and C. And it all depends on the size of the tumor and where it is and how it is impairing the function of the cords. Obviously, if you have a tumor on the cord, your voice is going to be different because the voice is projected by the movement of the vocal cords. So what kind of stage would it be with this tumor?
say what it involves again? I'm sorry.
It involves both vocal cords, but does not impair mobility. So you have T1A, T1B, T1C, and T2. I'll give you this one. It's T1B.
What's T1A?
T1A is that it involves one vocal cord.
Ah.
So since we're on since we were on the subject of salivary gland and the function of saliva, can anybody tell me what the Stenson duct is and which gland it is associated with?
Associated with the carotid gland.
Okay. It is a duct that is actually attached to the salivary gland, attached to the parotid. So we know that there are several things that are risk factors for larynx. Among them is smoking. Among them is alcohol. What else? What other things are a risk factor for larynx cancer?
Poor diet.
Poor diet, yeah, poor nutrition. What else? It actually includes most of the head and neck cancers, this particular one that I'm looking for. Comes on the news every so often. Pardon? HPV, yeah, HPV is a risk factor for not only larynx cancer, but most of the head and neck cancers. So the pharynx, how many parts of the pharynx are there? The pharynx is divided into how many parts? 3. Okay. Would you care to give me them?
Oropharynx,
Oropharynx.
nasopharynx,
Mm-hmm.
laryngopharynx.
Laryngopharynx, yes. Laryngopharynx. Oops,
Sorry.
it's okay. Okay, so let's stop head neck there. Let's go on to urinary tract. We did discuss the penis. We'll do a couple of those. What is the most common histologic type of penile cancer? Skin cancer, that's not actually histologic.
Oh, it's treated as a skin cancer.
Pardon?
It's treated as a skin cancer.
It's treated as a skin cancer, but that's not what I'm asking. So what is the most common histologic type of penile cancer. Think about the skin cancers. What's the type of skin cancers you can get?
Basal, squamous,
Basal,
squamous,
excuse me, say again, basal,
basal, squamous,
squamous,
melanoma.
okay. So, which would you say would be the main histology?
Squamous.
Squamous, yeah, squamous. How do we treat the penile cancers? We know we treat them as a skin cancer, but because of the, how should I say this politely? Difficulty in positioning.
Put it in a box.
You put it in a box. What kind of box?
Terrifying.
Yeah, okay. Yeah, it's, it can be treated in a water bath, but it's kind of difficult to do that. So it's usually treated in a wax box, which is inserted over the penis, and you treat it sort of laterals this way. So the penis is in a box, treat it this way. So let's, oh, where did my stuff go? Damn it. Okay, never mind, I'll get it later. So there is actually a good picture of it. See if I can
Don't leave now.
find it.
Don't leave now.
Uh-huh. Yeah, so on page 691, guys. Sorry, ladies, since our male contingent is chicken. Okay, so, did I say that out loud? Okay, so this is, if you look at figure 3314, this is basically what it looks like in actual practice. You have this box, and it's, we treat it from the site. And it's wax, and it's made in 2 parts. And you just join them together carefully. And you treat it that way.
Now, is that like, you would say that, kind of like you do with the backlog? Or is that only treated once? You only treated once?
What do you mean only treat it once?
They come in for a series?
Oh, yeah, yeah.
You would see-
You can treat almost everything is treated in a series of treatments, and the penis is no different.
So you would say, so that would be also labeled and saying.
Oh, yeah,
We
exactly.
do whatever.
It would be, no, it would be made specifically for the patient, and you would put his name on it, and you put it in an area kept obviously clean, because you don't want to get anything infected or anything, which is really bad. The only problem with that is, if it was a wax block, what would that, we talk about skin sparing. Excuse me, we talk about skin sparing. Just going off topic for a minute, what is skin sparing?
Trying to preserve healthy skin, right?
Pardon?
Trying to preserve healthy skin. You're treating,
Yeah, kind of.
not good.
It basically, the treatment is using the high-powered X-ray machines that we do, the 100% of the dose is below the surface of the skin. Depending on the type of the energy of the machine, or the energy of the machine, 6 MV machine, the 100% of the dose, or D max as it's called, is what? How much underneath the skin? Can you remember? .5 centimeters. So, that being said, we are putting a wax block around this area. Do we still have skin sparing? Somebody's
Seem like
no, shaking their head. No, we do not. That destroys it. Because that, according to the machine, it doesn't know any better. It sees this block, and it's what they call soft tissue equivalent. So it treats it like skin. So
Can't
you've
that be
got,
accounted for?
pardon?
Can't that be accounted for when you're setting your,
No, because the problem with, as we were saying, is treated like a skin cancer. So you want 100% of the dose on the skin. So the wax block brings the 100% dose to the surface of the skin, which means the patient's skin is going to get very sore. And we can only imagine what that feels like. And I can assure you, it does get very sore and very red and very itchy, and it can cause, depending on how the patient treats it, moist desquamation. So anyway, so you can have the penis treated in a water bath, or with this, and the water is tissue equivalent as well, so it does the same thing. Or in the wax bolus like this, or a wax block like this. So which urinary organ, and we count the penis as a urinary organ, is most common? Think about your urinary organs. Which is most common? Cancer in which organ is most common?
Bladder?
Is it?
Probably not.
It is actually.
Oh, okay. I'm like,
I'm sorry, I'm just playing devil's advocate here, sorry for that. Yes, that is correct, it is bladder. So, talking about bladder, which is, again, histology, which is the most common histologic type found in the bladder? This one's an odd one.
Is it the transitional?
It is a transitional, yeah. You can probably count on the fingers of one hand how many bladder cancers are not transitional cell. Most bladders are transitional. What about kidney? What's the histologic form of kidney cancer? Most common histologic sign, kidney cancer. So what kind of cancers are in the kidney? You have
Renal cell.
renal cell, yeah. What else do you have? What else? You have transitional cell. What else do you have?
You already said, what did you already say? You said we have transitional cell or renal cell
Well, I'm asking what types of cancers
in the kidney.
in the kidney.
Okay.
I'm not asking what type yet, but I'm asking what types you can have. So anybody tell me what types you can have? So anybody?
Yeah.
Okay, so I'll ask the other question then. What is the most common type? Oh,
I think that's renal cell.
it's renal
So
cell.
what were the other ones? I know there were.
Well, there's,
Renal, pelvic, urinary person.
yeah, there's urinal, yeah. There's also adenocarcinomas that are relatively rare. And there's transitional cell, which again are, depending, also it depends on whereabouts in the kidney it is. If you have renal pelvis tumors, they tend to be more transitional cell. If you have the kidney as a whole, it tends to be more renal cell carcinoma, so it almost depends. Okay. So what is the first type of treatment for kidney cancer? What is the most common type of treatment for kidney cancer?
Surgery?
Surgery. Surgery. Why? Why surgery? You can, hopefully when you have two, yeah, you can live without one. If you have one, if you only have one, mind you, that might cause a little bit of difficulty. But yeah, the reason why they do surgery for kidney cancer is that it can be easily removed. The other thing, of course, if you're removing the kidney, you also remove the adrenal gland, which causes problems with your hormone status. Because, think back, what hormones does the adrenal gland produce? Anybody? Anybody remember that far back?
Is it cortisol or?
Cortisol, yeah,
Adrenaline.
makes sense, doesn't it? Yeah. And you can live without the adrenal, you can live without a kidney, as long as you have more than one. If you don't have more than one, then you have a problem. But they'd still probably take it out, and then you'd be on dialysis. I remember a gentleman I treated not so long ago that had 3 kidneys. 3 kidneys, 3 fully functional kidneys. The third one wasn't a transplant or anything. He had 3 fully functioning kidneys. And he had 2 on one side and 1 on the other. And there was 3 ureters into the bladder, and yeah. It was quite a shock when we did the,
Did he have any like specific issues because of that, or?
no, he didn't even know. The only reason he knew is because he was complaining. I think he was a bladder patient, if I remember correctly, and we did what was called, or the diagnostic people did what was called an IVP, which is an intravenous pyelogram, and that shows off the function of the urinary tract. And somebody went to this gentleman and said, "Do you realize you had 3 kidneys?" And of course, this guy stopped it. Huh? When are you supposed to have it? He had, literally, he had no idea that he had 3 kidneys, because he had never been sick before. He had never had an IVP or any kind of intervention with anything. So, anyway. Upset the point. So you would have more than one. Same as a gentleman I saw that had 13 thoracic spine. Caused the problem because if you're positioning a patient and the doctor says, "I want to center on T10, you either count up or down. So you usually either count from let's turn around here. Come on. Yeah. There we go. So where would you start? If you had to count down to T10, where would you start? What's the most common place to start up here? Which is the spinal, the C-spine, which actually juts out more? You can actually feel it on yourself. If you go back here, you can feel it. It's right about here. That's C7. That's the one that juts out. So it's that one. So this is 1, 2, 3, 6, 7. That's one. That's C7. So you go down. How many C-spine are there? Huh? 7, yeah. So the next one would be T1. So you go down 1, 2, 3, 4, 5, 6, 9, 10. Or you can go up. How many lumbar spine are there? Okay, 5. 5. So it's actually easier to go up. So here's 5, 4, 3, 2, 1, 12, 11, 10. It's actually easier to go up. But this gentleman had 13. So I started going up. So it was 5, 4, 3, 2, 1, 12, 11, 10. And then I worked my way down, and it worked in, there was 2 of them. We didn't end up in the same one, and I'm thinking, this is weird. So I centered on what I thought was T10, but counting from the back, counting from up. And the dog wandered in and he said, that's wrong. Why? He said, didn't I tell you the guy had 13 vertebrae? No. Oh, sorry, he's got 13 vertebrae.
We always learned it as breakfast, lunch, and dinner, 7, 12, 5.
Yeah,
That's why I was saying 8, because in my head, it was dinner was done, never get to dinner till 8. That's why.
yeah, that's a good one. That's actually very good. You basically use it for anything you can imagine. You know, if you have something like that, then use that. If you have something like, there's a physics one, which I don't know whether I mentioned, no, because nobody does superficial anymore. There's a superficial filter. What do filters do in X-ray? This is totally outside, but I just want to show you this one. What do filters do? If you put a filter in an X-ray head, I'm sure Mr. Graham has got to this, hopefully yet, still. A filter filters out the weaker X-rays.
It adds unnecessary dose.
That's exactly it. So there's a thing called a Torreus filter, spelled T-H-O-R-E-U-S, I think. Anyway, and it's comprised of 3 different metals. There's tin, there's copper, and what I would say would be aluminum or aluminum. And the way to remember, or the way I remember which position each of these metals are in, is tin, copper, aluminum. So it's actually done with the chemical symbols. So there's SN for tin, Cu for copper, and Al for aluminum. But if you think about it, there's tin, there's copper, and there's aluminum. Anyway, use what you remember for these types of things. Okay, so the other thing, before we go off of, I meant to ask this for the head and neck. I sent you, I believe, the cranial nerves. Why do we need the cranial nerves for head and neck? We need to know the cranial nerves for head and neck, or at least be aware of them. Yeah, it's because there's so many of them and they affect so many different parts of the area that that's basically what we need to do. We need to be aware of the cranial nerves. So kidney, back to kidney. What are the main contributing factors to kidney carcinoma? There are several, but what are the main ones?
Drinking, alcohol?
No, not for this particular one, but the other. Usually it's smoking and drinking, right? If we discount alcohol, smoking, okay. The other one, another one, is obesity. That's the main 2. Drinking does come into it, but not as a major cause. Okay, let's get on to breast. So, mammograms. What age?
Oh, we're already on breast.
We're already on breast. You can ask some questions later and see if you can find some. Let's do breast.
Is it 40 question or 50 question exam?
Pardon?
Is it a 50 question exam?
It's actually, I think this one is 47.
Okay. Oh, no, I'm so sorry. What are you saying? Isn't it like 40, age 40?
Pardon?
For a mammogram, age 40?
Age 40. For a normal risk patient, it is 40. What if you're not normal risk?
As soon as you can.
As soon as we got the one.
Yeah, you basically get it as soon as you can, as soon as you can persuade your physician to do it. We discussed DCIS. 2 questions on this one. What is DCIS?
Ductal carcinoma in situ.
Okay, and what stage is it? It's classified as stage 4.
1. Oh, 0, 3. Low, I thought.
Pardon?
I thought it was very like basic, very low.
Yeah. So it's not 1.
0 or 1.
It's 0, stage 0. So do we treat that? DCIS? Is it treated? Or is it just left to its own devices? Yeah, it's treated. Because we know it's eventually going to start being invasive. So we want to do that. What is the name of the tail of the breast tissue that goes into the axilla? Pardon? Tail of Spence. There's another name for it, which is called the axillary tail, but you will see tail of Spence. Inflammatory breast cancer. Is, as we all know, very aggressive. What stage is it always done as?
4.
Pardon?
3 or higher?
Okay.
4.
Yeah, it says, I think it says in the book 3 or higher,
Yeah, that's
doesn't
what I
it?
wrote.
Yeah. Normally you would see it classed as stage 4. So if it gives you the option, I would say class stage 4. Because it 99 times out of 100 is classified as stage 4.
You mean if you give us the option?
Sorry?
So you mean if you give us the option?
Yeah, it's,
Wait.
the problem is it tends to be, it's not very rare, but it's unusual. So they tend to make it stage 4 because it is very aggressive. I've seen patients come in with inflammatory breast cancer and we treat it immediately. And before we are finished treating the cancer on one side, it's actually on the other side. It moves it that fast, so it really is very aggressive. And it's usually in young women, which adds to the problem. Okay. So if we had to treat, I'm trying not to give you the exact question here, so bear with me.
It's cool.
Um,
It's clean.
If we were treating a breast with a supraclavicular field, and they wanted to increase the dose at the mid-axilla, what treatment field might be added to get to that stage?
Say that again.
If we're treating the
I lost you.
supraclavicular
I
field,
lost you after mid-axilla.
If we're treating the supraclavicular field and the physician wanted to add a field to bring the dose in the mid-axilla up to what he wanted to do, what would that field be called? I think we touched on this last week.
Is it the boost?
Yeah, but it's not just called the boost. This particular one is not just called the boost.
Okay.
It's called a PAB, or a posterior axillary boost. Commonly known to everybody as a PAB. Where do breast tumors most commonly occur? Which quadrant?
The outer
Upper outer, yeah, or outer upper, what to say. Yeah, same difference. It's usually called the upper outer, but whatever works. Yeah, it's most common upper outer. So we know that the breast size can vary. But where does the lower edge of a quote normal breast come down to as far as the ribs are concerned?
okay.
Okay. Yeah, well, as we're saying, it depends on
Yeah.
how big the patient is.
Is it the sixth rib? Between the second and sixth, I thought?
Almost. What one?
Pulling it out of thin air.
It's the fifth. It's the fifth rib. Okay, so we've got some here that, if everybody has looked at their chapter here. Well, before we go any further, remember when we were talking about breast reconstruction? And this is not in the test, this is just something that I found after we were talking last week, or the week before last. We were talking about breast reconstruction and breast implants. And there is a specific, very rare cancer associated with breast implants. And it's called, you might want to write this down, associated anaplastic large cell lymphoma. Breast implant associated anaplastic large cell lymphoma, commonly known as BIA-ALCL. And that's a particular type of very rare cancer that has been noted in some women who have had breast implants done. And the implants tend to be the textured ones rather than
Saline?
the non-textured ones. And they can either be silicone or saline.
Like there's textured and non-textured breast implants.
You can get textured and non-textured, yeah. The textured ones look and feel rough. And I think they're the older type of breast implants. I'm not saying they still could be used, but they tend to be older types. So, yeah, so this is what they're called. Breast implant associated anaplastic large cell lymphoma.
Wow.
So there you go.
It's a whole thing.
Yeah.
It was like, BIA.
BIA dash ALCL.
Oh, it was just, okay, that makes sense. Never
Yeah.
mind.
So it's the initials of breast implant associated anaplastic large cell lymphoma.
For some reason, I thought it was the last four was like a number.
No.
That makes sense.
No. So anyway, that's what that's. So anyway, the next couple, we're going to see how well you think this works. So, yeah, sorry. So if you had a tumor which was 9 centimeters with skin invasion, what T stage might that be? Remember, you have, in this case, you have TIS, which is in situ, T1, T2, T3, T4. On all of the next, you have all of these T stages to choose from.
Skin invasion,
9 centimeters tumor with skin invasion,
T4.
T4.
Something about
Yeah, you're right. Okay, next one. 3.5 centimeter tumor near the nipple. .5 centimeter.
I'm just gonna guess T2. I don't remember the.
You guessed
lower one.
correctly.
Yes.
Yeah. Okay. 1 centimeter tumor in the upper outer quadrant. That's T1. That is correct. T1. So, 7 centimeter tumor in the upper outer quadrant with the extension into the skin.
T4. 3 and 4.
It's actually T3.
I thought I read somewhere any invasion of the skin is 4, but I don't remember where it was at.
Okay. Next one is 1.5 centimeter tumor near the nipple.
2.5?
Pardon?
Did you say 2.5?
1.5.
1.5.
One.
T1. Thank you. Yes. And next one, 3 centimeter tumor invading chest wall.
Oh no.
T4.
T4. That is correct. Okay. What's the ligament holding the breast in place?
Spencer.
Pardon?
Cooper. Oh no.
Cooper.
Cooper.
Wait, what's the
Cooper.
suspensory ligament?
Pardon?
There is a suspensory ligament, right?
There is a sensory ligament,
Oh,
yes.
sensory.
but they're the
I thought it was suspensory, like.
is Cooper. Well, the Cooper ligament is a sensory, yeah, ligament. Okay.
Maybe that's why I don't have one.
Okay. So if you were to tell me what the dose was that we would give a patient when we're doing tangential treatments, what would be the standard dose delivered to a patient with using tangential fields? So let me give you a list of doses. 4,500 to 5,000, 5,000 to 5,006, 6,000 to 6,006, 7,000 to 7,006.
What area did you say again?
You just said
An area that you're treating with tangential treatments. So after the treatments are completed, or after the tangential treatments are completed, what kind of dose would you expect?
45 to 50.
That would be correct. There might be also a boost, which would bring it up to another 1,000. But following the tangential treatments, that would be 45 to 5,000, yeah. So we all know where the internal mammary lymph nodes are, right? Where are they? Just so that we know where everybody is.
Along the sternum between the ribs.
Along the sternum, what?
Along internal mammary,
Yeah,
along the sternum between ribs 2, 3, and 4. In the
they
intercostal
actually
space.
go all the way down.
In the intercostal space.
Well, no, they're along the sternum, they're beside the ribs, yeah. So if we were treating the medial field of the breast, so this comes in this way, and we need to include those internal mammary nodes. What would be the border of the medial field? Sternum? Sternum's this wide,
Middle?
so you have to be a little more specific.
Middle line, that's fine.
Midline,
You said
Midline?
internal mammary?
yeah, if you're wanting to include the internal mammary nodes, where would your medial border of your field be? So this is the sternum, right? And your nodes, you know, go along both sides of your sternum. So to include those, where would your field be? We've got midline. Any advance on midline? You're right, it's midline. Okay, so we go back to our patient that we're treating the supraclavicular field. I want to know what the dose might be to the supraclavicular field.
Is that another like word for midline that's used?
No.
No?
No.
Just midline?
Midline. Or you could put midline of the sternum.
Okay.
So if we know that for the tangent fields, we're going to be giving 45 to 5,000. That's before any boost comes along. So what would we be giving to the supraclavicular fields? Or the supraclavicular field?
Now, would this be the PAB we're doing?
No, never mentioned PAB. Supraclavicular field, just one field on the supraclavicular area. Don't mention PAB unless it's asked for, because not many people do it anymore. So what would the dose, what might the dose be? If you're giving 45 to 5,000 for the tangents, what would you be giving for the supraclavicular field? Don't overthink it, guys.
Same thing?
Same thing, yeah.
I was thinking 45.
4,500 to 5,000. Okay. Okay, so we have some more measurements here. So what is the stage of a breast cancer that is 3 centimeters in the greatest dimension with 3 positive axillary lymph nodes?
Can you repeat that one more time?
The stage of a breast cancer that is 3 centimeters in greatest diameter with 3 positive axillary lymph nodes.
One?
I'm looking for stage, not
Sorry.
N1, T1, whatever. I'm looking for stage. So it's either stage 2, stage 3, stage 4, or stage 1 for that matter.
Three positive auxiliary lymph nodes.
It is stage 2B. 2B. Okay, here's another one.
I like these ones.
So again, you have a choice of either stage 2 or stage 3. What is the stage of breast cancer that has grown into the chest wall and has 8 positive axillary lymph nodes?
3.
3. Yeah, 3B actually. Okay, stage is a stage of an inflammatory breast cancer that has not spread to distant organs but has distant lymph node involvement. All you need to know is that it's an inflammatory breast cancer. Stage 4, yeah. You don't have to worry about the detritus of the rest of the stuff. Okay. Looks like we can do this afternoon's ones this morning, and then we can get you out of here if you'd like.
No way. No way.
Okay. We'll stay here all day if you want. Okay, what stage is a 6-centimeter breast cancer in the upper outer quadrant? So again, you have T1, T2, T3, or T side 2. 6-centimeter breast in the upper inner quadrant.
For inner?
Upper inner, yeah, doesn't really matter.
Please in the front.
All you want to concentrate on is a 6-centimeter breast
2.
cancer. 3. Okay. So, which of the following techniques may be used to adequately irradiate the internal mammary lymph nodes while limiting the exposure to other organs? We discussed this, I think, last time. So, what did we discuss? What did we, when we were saying that we wanted to treat the internal mammary chain, what kind of treatment did we suggest we might use? So we can use a 6 MV photon. We can use electrons. We can use both photons and electrons. Which would you say would be the one that you might want to use? Both the photons and electrons? Yeah, actually, you're correct. You're correct. A photon-electron combination is easier. Okay, so to finish this, I have 4 true or false questions. Most salivary gland tumors are squamous cell carcinomas. Okay, actually they're not. These are the ones that as the odd ones out. Let me just see here, just make sure. I just want to make sure here, hang on. Most of them are, this is the one that is the exception that proves the rule. Most of them are adenocarcinomas. Okay, the primary function of the oral cavity is respiration. What is it then?
I don't know how to say it.
Can anybody help her out?
Digestion.
Digestion, yeah.
Oh,
Ingestion, digestion, yeah,
I was thinking just specifically saliva. I was gonna say
yeah, so it's basically ingestion. But, or digestive activities, or call it what you will. Most breast lumps feel hard and have irregular edges. Yeah, that's right. What do most breast lumps feel like? Hmm? What? What do most breast lumps feel like?
Round.
Right? Yeah. Yeah. Most of them are, do they feel hard?
Ah, squishy.
Yeah, some of them feel hard, but they're usually not irregular. Okay, last one. Radiation therapy is the only treatment necessary for T1 and T2 breast cancers.
False.
False. That was a very explicit answer. So what other treatments? It says radiation therapy is the only treatment necessary for T1, T2. What other treatments are there?
Surgery.
Surgery and
Chemo.
chemo. Not necessarily for stage 1, but certainly for stage 2. Or hormones, depending on your patient's age. So, questions? Yes, ma'am.
Just for that one that had skin involvement that you said was T3, in the book it definitely says it's T4, so I wanted to make sure which one I need to do. Is it changed just on slides?
Which one is that, dear? Do you remember?
It was 7 centimeter with skin involvement and, yeah, skin invasion. And on page 716 at the top, it says tumor with extension to chest wall or skin is classified as stage 4.
Okay.
I just wanna make sure I got it right.
So T3 and up.
Oh, sorry. I just read it last night, that's why it's sticking in my brain.
So is it, where is it?
At the top of the page, second column, on page 716.
16. Okay, here we go. Stage, okay. The larger the tumor, the higher the T stage, obviously.
It's in the paragraph above pathologic stage.
Yeah, I see it. I'm just reading it.
Chest wall or skin is T.
Clinical and,
You know what?
but clinical stage is the larger the tumor, the higher
Whatever's gonna give you the
the,
right.
chest wall or skin ulceration or skin nodules. We're not actually at ulceration or skin nodules. All we're talking about is skin invasion.
Okay, so maybe it hasn't come to the surface externally
Yes,
then?
that's correct.
Okay.
So if it's come to the surface, if it's ulceration, you remember the ulcerations that we saw? That was stage 4.
Okay.
Or if you have skin nodules visible on the skin, that would be stage 4. But if it's just gone into the skin and it hasn't gone any further, then that can be a stage 3.
Erupted, okay.
Yeah, right? Does that make sense?
Yeah.
Okay, good, okay. So why don't we take half an hour, guys, back at 10, and we'll do patient care.
11.
Back at 11.
Back at 11?
That's
Time
not
change.
right.
Back at 11. And then we'll do the, sorry, yes,